Hello, and welcome to Pharcast. I'm your host Ahmed Abdel Fattah. I'm practicing pharmacist and current postgrad PharmD student at University of Alberta. Today we are discussing patient optimization and selection in a precision medicine controversy. In metastatic castration-resistant prostate cancer with HRR mutation gene patient following progression on androgen deprivation therapy, those patient therapeutic options have been limited, and several factors must be considered when incorporating of PARP inhibitors into their routine prostate cancer management, including choosing the right medication, the right PARP inhibitor, and the most important, choosing the right patient. Specifically, is it BRCA mutated specific gene or non-BRCA mutated specific gene type of patient? According to the Globocan 2018, prostate cancer is the second most common malignancy and the fifth cause of cancer death in men worldwide. In Canada, prostate cancer is the most common cancer among Canadian men, excluding non-melanoma skin cancers. Around 24,600 Canadian men will be diagnosed with prostate cancer. This represents 20% of all new cancer cases in men in 2022. Around 4,600 Canadian men will die from prostate cancer, and this represents around 10% of all cancer deaths in men in 2022. It is the third leading cause of death from cancer in men in Canada. On average, 67 Canadian men will be diagnosed with prostate cancer every day, and 13 Canadian men will die from prostate cancer every day. Metastatic castration-resistant prostate cancer is an aggressive and fatal disease. It's a form of prostate cancer that has spread to other parts of body and keeps growing even when the amount of testosterone in the body is reduced to very low levels, with an estimated median of survival of 36 months. Prostate cancer therapy, the initial treatment is androgen deprivation therapy, which starves the prostate cancer cells by targeting their dependence on androgen, causing androgen receptor signal transduction. However, there are significant differences in individual responses, and other treatment options are limited following the androgen deprivation therapy, including taxanes, abiraterone, enzalutamide, and radium. But outcomes continue to remain poor due to progressive resistance to therapies. Most hormone-sensitive patients progress to castration-resistant prostate cancer patients, which is the leading cause of death. Patients with prostate cancer, especially castration-resistant prostate cancer, often have a mutation in genes such as BRCA1, BRCA2, ATM, CHEK2, RAD51D, and PALP2. BRCA1 and 2 mutations, specifically BRCA2, are the most common DNA repair gene defects in patients with metastatic castration-resistant prostate cancer. Looking to the PARP inhibitor is an oral agent that exerts their activity via synthetic lethality. Synthetic lethality is a situation in which the presence of deficiency in HRR mutation and PARP inhibitor alone would not independently cause cell death. In other words, both of them need to be available to initiate cancer cell apoptosis. In the last decade, genetic sequencing have identified new molecular targets in prostate cancer and pathways that promote tumorigenesis and can be targeted therapeutically. In May 2020, it was the first approval for poly-ADP ribose polymerase inhibitor, PARP inhibitor olaparib, was granted approval by US FDA for the use in metastatic castration-resistant prostate cancer. However, there is a clinical dilemma regarding optimizing patient selection and positioning of this group of medication in the pharmacotherapy plan of the patient. Is it first line? Is it second line? It's monotherapy? It's going combination. So it's very important to choose the right patient and also to choose the right PARP inhibitor. My big question will be in adult male with metastatic castration-resistant prostate cancer with alteration in HRR-associated non-BRCA genes, whose cancer has progressed on prior treatment with androgen receptor-directed therapy and taxane. Would treating with PARP inhibitor improve outcome, which is radiological progression-free survival and overall survival, compared to standard of care of physician choice between brackets androgen receptor signaling inhibitors? To answer this question, I need to run my research through different resources, including PubMed, using the keywords of PARP inhibitor, metastatic castration prostate cancer, olaparib, rucaparib, niraparib, and BRCA. Going through different guidelines like NCCN, ESMO, ASCO Clinical Practice Guideline, and Canadian Guideline, and EAU Guidelines. Go through Dynabent, ASCO and ESMO conferences update discussion, and the Canadian Association of Pharmacy and Oncology, the Alberta Health Outpatient Cancer Drug Benefit Program, and Canadian Drug and Health Technology Agency database. Ended up selecting two studies, which was the main studies during the granting FDA approvals for olaparib and niraparib in MCRPC. As well, through discussing those two studies, I will clarify the clinical controversy that we are facing today during the patient selection process. As DNA repair gene defects represent a predictive biomarker that can currently guide targeted therapy in patients with advanced prostate cancer. While patient will get the most clinical benefits, which patient would choose BRCA or non-BRCA or both? The FDA granted a breakthrough therapy designation for niraparib for the treatment of patients with BRCA1/2 mutated metastatic castration-resistant prostate cancer patients who have previously received taxane chemotherapy and androgen receptor targeted therapy. The designation was based on finding from multicentral open-label phase 2 Galahad trial that is investigating the safety and efficacy of niraparib as a PARP inhibitor in men with metastatic castration-resistant prostate cancer who have DNA repair abnormalities, which is published in Lancet Oncology and led by Dr. Smith and his colleagues. Galahad is an open-label intention to treat phase 2 study assessing niraparib 300 mg once daily in patients with metastatic castration-resistant prostate cancer and DNA repair deficiency with disease progression on taxane and androgen receptor targeted therapy. DRD status was evaluated by plasma or tissue-based test and defined as having a biallelic alteration in BRCA and non-BRCA defined genes. The primary endpoint was objective response rate for participants with measurable metastatic castration-resistant prostate cancer and BRCA DNA repair deficiency. ORR was defined as percentage of participants with BRCA DNA repair deficiency and measurable disease whose best response is either complete response or partial response as per response evaluation criteria in solid tumor, and with no evidence of bone progression as per prostate cancer working group 3 criteria. The study results with and intent to treat 223 patients, which representing 77% of 289 patients were included in the overall efficacy analysis population, which included BRCA with number of patients of 142 patients and non-BRCA with 81 patients. In BRCA cohort with 76 participants, objective response was 34.2%. The composite response was 63% and median duration of objective response was 5.5 months. The median rPFS was 8.2 months and overall survival were 12.6 months and PSA 50 was 50%. As a secondary outcome, we look to the non-BRCA analysis. In non-BRCA cohort with 47 patients, objective response was noted in 10.6%. Composite response was 17% and duration of objective response were 3.8 months and PSA was only 3%. In the safety analysis population, the most common treatment adverse effect of grade if any grade was nausea by 58%, anemia by 54%, and vomiting by 38%. The most common grade 3 or worse events were hematological, mainly anemia and thrombocytopenia. Looking to the strength and limitation of the study, Galahad study is a large multicentral phase 2 study with participants from 15 countries. The participants were similar to each other in terms of their disease and type of the stage of the disease progression. Limitation: 9% of patients experienced disease progression before their first study evaluation and discontinued treatment. 89% of participants in the BRCA group had BRCA2 mutation, which is unclear that those with BRCA1 mutation would respond similarly or not. In conclusion, niraparib demonstrates clinical activity in patients with treatment of refractory metastatic castration prostate cancer with durable response, particularly in biallelic BRCA mutation carriers. This study was funded by Janssen Oncology. In contrast, PROfound provided data for the FDA approval of olaparib on the basis of double-blind phase 3 randomized controlled trial in men with metastatic castration prostate cancer who had received prior androgen axis targeting agent and had one of 15 HRR mutation, which is BRCA or non-BRCA patient. It's published in New England Journal of Medicine and led by Dr. Saad and his colleagues. PROfound study is phase 3 randomized multicentral trial evaluating the efficacy and safety of PARP inhibitor olaparib versus physician choice of enzalutamide or abiraterone acetate in pre-treated metastatic castration prostate cancer patient with qualifying HRR mutated genes. Patients were grouped into two cohorts. Cohort A was BRCA1, BRCA2, and ATM mutated, and cohort B with the rest of the mutated genes. PROfound results with 778 patients were randomized 2-1 olaparib 300 mg twice a day, or the physician choice of enzalutamide 160 mg a day, or abiraterone 1000 mg a day plus prednisone 5 mg twice a day. The primary endpoint was radiographic progression-free survival in cohort A, assessed by blinded independent central review and analysis of stratified long-rank test. Crossover to olaparib was allowed after blinded independent central review progression. There were 4,425 men screened for PROfound, leading to 245 randomized to cohort A and 142 randomized to cohort B. The median treatment duration was 7.4 months for olaparib group and 3.9 months for enzalutamide/abiraterone. Moving to the punchline, there was statistically significant benefit in cohort A for rPFS as well as for cohort B. but also for cohort A and B statistically significant rPFS benefit, which led to the FDA approval for 14 gene panel. On one particular gene only was removed. Olaparib was associated with improved rPFS compared to enzalutamide abiraterone among with patients in cohort A, with HR of 0.34, which was consistent across the majority of subgroups assessed. Furthermore, patients in cohort A had confirmed objective response of 33% of olaparib, compared to 2.3% of enzalutamide abiraterone. A key secondary endpoint was time to pain progression in cohort A, which also favored olaparib. The most common adverse event were anemia, with 46% versus 15%, nausea, decreased appetite, fatigue for olaparib versus enzalutamide/abiraterone. Among patients receiving olaparib, 16.4% discontinued the treatment secondary to the adverse event, compared to 8.5% of patients receiving enzalutamide abiraterone. 4.3% of patients receiving olaparib had a pulmonary embolism compared to 0.8% among those receiving enzalutamide, however, none of which were fatal. Study limitations. The data from the trial was only presented as a cohort A versus cohort A plus B, which leaving a lot of question regarding to group B alone. Without BRCA1 and 2 mutated patient experience the same degree of clinical benefit or not. When looking specifically to cohort B patient, there was no advantage to olaparib in rPFS by blinded independent central review. In conclusion, in men with metastatic castration-resistant prostate cancer who had disease progression while receiving enzalutamide or abiraterone, and who had alteration in gene with a role in homologous recombination repair, olaparib was associated with longer progression-free survival and better measures of response of patient-reported endpoint versus enzalutamide or abiraterone. In my conclusion, patient with mCRPC and HRR mutation with prior treatment, olaparib improved rPFS and ORR compared to conventional therapy. However, it was specifically noted in the patient with BRCA1, BRCA2, and ATM mutation. My conclusion was agreed with the Canadian vision of managing this category of patients. According to CADTH, olaparib is the only PARP inhibitor approved for mCRPC, and Alberta Outpatient Cancer Drug Benefit List eligibility criteria included that olaparib monotherapy for the treatment of metastatic castration-resistant prostate cancer and deleterious or suspected deleterious germline or somatic mutations in the HRR genes, BRCA1, BRCA2, or 8ATM, who have progressed following prior treatment with an androgen receptor targeted therapy. Also, olaparib may be offered to patients who are unable to tolerate an androgen receptor targeted therapy and patients who have received prior taxane-based chemotherapy to be eligible. In contrast, NCCN guideline recommending offering patients with mCRPC and progression following docetaxel chemotherapy a further life-prolonging treatment option, including olaparib in case of DNA HRR alteration, with no BRCA specification. So what we should do now as a clinician? To summarize all this point, I want to start with what we know. We know that PARP inhibitor in particular with BRCA2 showing a great result in mCRPC patient with average of 50% of clinical objective achievement, along with some additional percentage of stable disease for some period of time. Now, if I have a patient with non-BRCA associated gene, then it's not that I would exclude recommending TRIM-BARB inhibitor, but certainly I would look for another alternative. My little worry that just because that patient mutation is non-BRCA, he will not be eligible to be treated with BARB inhibitors. However, there is likelihood that this patient could be benefit from the BARB inhibitor, specifically olaparib and niraparib. As opposite to doing something else such as another conventional therapy, I think it's very crucial to consider patient quality of life and to care about shared decision making. Finally, we need better quality evidence to provide definitive answer for this question. Ideally, we're looking for a large RCTs with proper randomization and comparable studies with head-to-head comparator. We need a longer follow-up period. There is more updated trials presented in recent ASCO and ESMO congresses. I highly recommend to check most updated studies like PROPEL, Magnitude, and BRCA-WAY. You were listening to Ahmed Abdel Fattah. You can contact me through my email amabdelf@ualberta.ca. Thanks for listening. Until next time.